right, yeah. So, do you want me to read this one? 36. The 36-year-old man is diagnosed with familial adenomatous polyposis coli, which of the following is a function of the APC gene? Sequestration of beta-catenin, stimulate translocation of beta-catenin to the nucleus of the cell, forms a complex that degrades beta-catenin, stimulates the WNT receptors, or none of the above. What an awful question. I have no idea on that.
Yeah, so it is kind of complex, I can say. So
I think the answer is WNT. I remember it from last year. I think just remembering it, not understanding.
So it has something to do with the WNT. That's correct. I think WNT stands for wingless something, right? Wingless type pathway. Anyway.
Let me look it up. Yeah, I know it's complicated. Oh yes,
So,
yes, you're right. It's WNT signaling pathway.
Yeah. So yes, it has something to do with that. I can agree with you. It has something to do with the WNT pathway. Okay. Is anyone really interested about knowing what's going on in here, or just about this? It's kind of complex. If you're interested in really learning the whole thing, I can go through the details. Or if you just want the answer and skip, I can do that too. But I prefer option one, generally, in everything. So, yeah. So what do you think? Should
maybe
we
just a brief outline of what it's about? Is
you
the
know,
answer
the problem
D?
is that the
is
problem is that yeah. So you said the answer D.
Is D the correct answer?
It's not D.
Oh dear.
Isn't. But it has. I agree that WNT pathway is integral to this. But APC does not stimulate the WNT pathway. It's actually it does the reverse. So let me just quickly explain. Try as much as I can to quickly explain here on the board what's going on. Okay. So let me tell you something. First, let's just make this board black so that everyone's eyes doesn't go blind. And okay, where do I start? So suppose that this is a cell, okay? Suppose that's a cell. And every cell, you know, it has genetic material inside, is that right? So that's suppose your DNA strand here. Is that right? On chromosome number 5, on the long arm of chromosome number 5, there's a special gene called APC gene, right? APC gene, a special gene called APC gene. Is that right? It's on chromosome number 5. What is this? On which category would you classify this gene? Anyone have an idea? APC gene is what? What's that gene? Anyone can tell me? APC gene belongs to which group of genes? APC is a tumor suppressor gene, right? Is that right? It's a tumor suppressor gene. Now, how does it work? You know, inside of this cell, there is, I will do it in a way that you will not forget it. Inside of the cell, there is a very, very nasty kind of a cat, okay? That's a nasty cat inside of the cell. This cat is called beta-catenin. So this cat is called beta-catenin. Normally, this cat does what? Normally, I'll just speak normally. This cat, if it's free, what does it have? What does it do? Beta-catenin, this cat inside of the cell, goes to the genome without details, it will stimulate cell proliferation. If it translocates to the genome, beta-catenin will do what thing? It will stimulate what? Cell proliferation. It makes the cell divide. Beta-catenin makes the cell divide. Okay? Now, normally, APC protein comes and catches this cat. So suppose this is ABC protein, right? With big mouth. It catches the cat, along with other proteins as well, okay? They form a complex that will degrade the beta-catenin. It will form a complex that will degrade beta-catenin. So in the presence, as long as APC protein is present, beta-catenin cannot stimulate cell proliferation. That's the function of APC. So APC does what? It binds to beta-catenin, and in the presence of other proteins, it will destroy beta-catenin. Okay? Now, what is the relation of, can anyone tell me what's the relation of this to WNT pathway? Okay. Some people joined late, but let me go back to the question and read it again so that you know what we're talking about. Okay? So let's go back to the question one more time. So this question is asking simply, there's a 36-year-old man, okay? This man is diagnosed with familial adenomatous polyposis coli. Which of the following is a function of APC gene? APC gene. What's the function of APC gene? So option A, it says sequestration of beta-catenin. Option B, it says stimulates translocation of beta-catenin to the nucleus of the cell. Option C says forms a complex that degrades beta-catenin. And option D, stimulate WNT pathway. And option E, nothing, none of the above. That's the question. Okay, so let's come back to the explanation. I've told you that APC is a tumor suppressor gene, okay? And the normal function of APC is that it produces a protein. And this protein is called APC protein, And this APC protein sequesters the cat, the beta-catenin, right? If there is no APC, cat is free. And this cat will go to the nucleus, play around the genes, and cause cell to proliferate. It will cause the cell to proliferate. Now, the WNT pathway, simply, it's a very complex pathway, but simply there is a receptor on the surface of the cell, and this receptor is called WNT receptor. Okay, this receptor is called WNT receptor. Normally, there is a protein which is called WNT protein that stimulates the WNT pathway. So when this is stimulated, when the WNT binds to its receptor, what's going to happen? What's going to happen simply is that there will be a signal to destroy APC. You get that idea? So when WNT pathway is stimulated, APC protein is broken down, and the cat is free to cause cell proliferation, right? Now, I have a question. I have a question for you. It can be a little bit, a deeper level question, but normally beta-catenin is destroyed by APC protein, right? Is there any other protein that you know of that can inhibit beta-catenin? Everyone knows that APC inhibits and breaks down actually beta-catenin. But is there any other clinically relevant protein that inhibits beta-catenin? Yeah. Anyone have an idea about that? there is another protein which is called, yes, I'll draw this protein here. This protein is a basket, and it has a gate, and it has a transmembrane domain. This is called E-cadherin. E-cadherin. E-cadherin is a, what's E-cadherin? E-cadherin is adhesion molecule. E-cadherin is naturally an adhesion molecule, but it also sequesters the cat, right? It also sequesters beta-catenin. So there's beta-catenin trapped inside here, okay? So it means that if there is a mutation of E-cadherin, there's two problems. Problem number one, the cell will overproliferate. Why? Because the cat is released, remember? Right? So the cell will overproliferate if there's a mutation of E-cadherin. And the other problem, the cell will not adhere to other cells because it's a glue. Is that right? What kind of cancer malignancy is caused by E-cadherin mutation? I'm about to be impressed by someone. What kind of malignancy is associated with the mutation of E-cadherin? You have to know this. It's a gastrointestinal cancer usually, yes. But what kind of, what special type? Okay, FAB is different story. As I told you, familial adenomatous polypo, excellent. Yes, Dr. Hanan, excellent. It's stomach. It's gastric cancer. E-cadherin mutation is common in not any gastric cancer, Linitis plastica, the worst type, the infiltrative type. Because remember, you are losing your glue. The cells are no longer sticky to each other. Is that right? There's no glue. So they are infiltrative. They infiltrate the wall of the stomach without causing any actual mass in the stomach. They don't form a mass. They don't form a coherent mass. They actually just melt into the wall of the stomach and cause just thickening in the wall of the stomach. And even when you do endoscopy, it can look normal, right? This is called Linitis plastica. Linitis plastica. So there are two clinical points important here that I need you to know about. Point number one, you have to be very clear about what APC does. APC not only, look carefully, it does not only sequester beta-catenin, it breaks it. It kills the cat. It also breaks it. E-cadherin does not break it. E-cadherin just sequesters it. APC mutation usually causes colorectal cancer. E-cadherin mutation usually causes gastric or esophageal cancer. Are we clear on these points? No problem? Everyone's clear about these points?
Yes, that makes sense. Thanks.
Great. Okay. I have another question. Since we are talking about genes, I think we need to clarify the important points for us, relevant for us in the exam. Do you know what is RB protein, an RB gene that's clinically relevant? RB gene. What's that? What's RB gene? Anyone? Just raise the hand and
Is this something that suppresses the cell cycle in the G1 phase or something?
Yeah, very excellent, actually. Really, yes. That's correct. That's very accurate. It's a protein that suppresses cell cycle, right? That's correct. RB protein is also called, it stands for retinoblastoma. It stands for retinoblastoma. Of course, it's found not only in retinoblastoma cells, it is found in every cell. It is found in every single cell of your body. But RB protein was initially discovered in retinoblastoma cells. That's the initial thing, initially discovered there. But they come to know later that, of course, when the cell wants to divide, suppose this is the DNA, and there are a group of genes which synthesizes those enzymes that cause DNA replication and synthesis of the cell spindle, the mitotic spindle, and the cell will divide eventually. Now, RB protein is all of the time, suppose that's RB protein. RB protein, let me draw the RB protein. RB protein is all the time, right, holding onto this key, right? That's a key. It's all the time holding into this key. This key is called what? E2F. This is called E2F protein, E2F, and this is RB protein. Now, as long as RB protein is holding into E2F, the cell will not divide. This is actually the central pathway of cell division, the central pathway. All other pathways eventually converge on this. Now, if there's a mutation in the RB gene, what's going to happen? Definitely retinoblastoma, but what else? Is there any other malignancy strongly associated with mutation in the RB gene? That was a question before in one of the exams. That's why I'm mentioning this. A mutation in the RB gene causes what kind of
Is it
other
osteosarcoma? Osteosarcoma?
Very excellent. Yeah, it increases the risk of osteosarcoma very significantly. I don't remember the exact number, but I think it's hundreds and hundreds of times. It increases the risk, especially of osteosarcoma, as well as, of course, retinoblastoma. Is that right? Now, if someone will answer the next question, I will give them $1 or whatever you would like, maybe in any currency that you like, because that's one dreadful question. We talked earlier about WNT pathway. Is that right? And we talked about beta-catenin, the CAT. How is this related to RB protein? Anyone have an answer to that? How is beta-catenin pathways related to the RB protein? Yeah? Any answer? How is this related? Okay. Do you want to know? Look, beta-catenin, I told you it goes into the nucleus and stimulate cell proliferation. But how does it do that exactly? How does it do that? It actually stimulates, it binds to another protein inside of the cell. Let me show you. This is the beta-catenin inside of the nucleus now, okay? This is the beta-catenin inside of the nucleus. Suppose that's your beta-catenin. It's more of a bunny than a whatever. I'm bad at drawing. But it finds another protein inside. Suppose it finds a toy to play with, right? This protein is actually a transcription factor. What does it do with that? It will stimulate, yes, another gene, and this gene, yes, it codes for something called cyclins. It codes, are you clear up to this point? It codes for something called cyclins. Now, in the cytoplasm, in the nucleus of the cell, there is an enzyme which is already present all the time there, right? That's the enzyme. It's already present there all the time. This enzyme is called cyclin-dependent kinase. That's called cyclin-dependent kinase. How can you remember this? Cyclin-dependent kinase needs a cycle, right? It needs a cycle. And when it drives this cycle, right? Now it is in the cycle, driving the cycle, and happy. When it drives the cycle, it will phosphorylate RB protein. When RB protein is phosphorylated, it leaves E2F. Free E2F activate DNA replication process. Is that difficult? It's not difficult, right? Do you know the full story right now? Now, I just explained the full story about APC, but in different portions. We said first, APC is tumor suppressor gene, right? APC binds beta-catenin. Beta-catenin normally goes to the nucleus, and it binds to a transcription factor which activate cyclines. Cyclines activate cyclin-dependent kinase. Cyclin-dependent kinase phosphorylates RB protein, which is mutated in retinoblastoma and osteosarcoma, and that leaves E2F to activate the cell cycle. That's the full story. That's the full detail. So if we go back now, let's go back and answer the question now. Now you will tell me. Read the options again, and now you tell me what's the answer. Yeah. Take your time, read it. Now you tell me. Yeah, excellent. That is, it forms a complex which actually breaks down beta-catenin, right? Option A is not correct. Option A, sequestration of beta-catenin, is not accurate. Sequestration of beta-catenin is by E-cadherin, as we've explained. Is that right? Anyway, let's go to the next question. Yes, Dr. O, please.
Yes, so the radial nerve passes from a posterior location anteriorly relative to the humerus, at which level? What is that? A structure arcade? I've never heard of that. Or cubital fossa, 10 centimeters proximal to the radiocapitular joint, the spiral groove, or ease off my page because I've got a small screen, so I can't read E.
Okay, but the answer was
medial.
The last option is medial condyle.
Yeah. I've never heard of option A, whatever that is.
Okay, I will explain that.
So I think the answer is spiral groove, right? D.
Okay. Now, the radial nerve enters into the posterior compartment of the arm through the triangular interval. Is that right?
Yeah.
Do you agree? Okay.
Yes.
So within the posterior triangle, within the posterior compartment of arm, it is traveling underneath the triceps in the spiral groove. Is that right?
That's right, yeah.
And then it will penetrate the lateral intermuscular septum and moves to the anterior compartment of arm. 10 cm proximal to the elbow, that is radiocapitular joint. So actually the point of the spiral groove is the entire spiral groove is behind the humerus. It is not the point at which the radial nerve moves anteriorly. It is not that point. Now,
so it's C then, 10 centimeters proximal to the joint, yeah.
10 cm proximal to the joint. That's the explanation and everything. Okay, let's move to the next one.
A 27-year-old male is suspected of having a depressed skull fracture following an RTA. He is otherwise normal and vitally stable. Which of the following is the most appropriate management? CT scan within 1 hour, within 8 hours, skull X-ray, emit and monitored GCS, or I can't read the last one because it says ISB, surgical boards over it on my screen.
MRI scan. Last one is the MRI scan.
All right, yeah. Okay, so he's got a fracture, and so you've got to do a scan, really. I would say A, that you can't hang around. I don't know.
That's correct. Yeah. So that's one of the indications for urgent CT scanning within 1 hour, which is depressed skull fracture. So there's, can anyone remind me of the indications? Yes. Anyone just unmute yourself and remind me of the indications of CT scan within 1 hour.
I know if GCS is less than 13, that's one of them.
Yeah, that's one of them. I agree.
Also, the Glasgow Coma score is 15, below 15 after 2 hours of admission.
I agree.
Also,
Dr. Hanan said.
Also, if there is any neurological deficit.
Excellent. Yeah, I do agree with that as well. Yeah. So, Glasgow Coma scale less than 15, 2 hours after admission. Glasgow Coma scale less than 13 at admission. And you guys said also depressed and basilar skull fracture and focal neurological deficit. What else?
Also post-traumatic seizure.
Post-traumatic seizure. Excellent.
And,
yeah.
And more than one episode for vomiting. More than 2.
Yeah. Yes. So those are all the indications within 1 hour. Within 8 hours, we know that age more than 65, we know the patient is on anticoagulants or antiplatelets or have a bleeding diathesis. The mechanism of injury is dangerous. What qualifies as dangerous mechanism of injury, by the way? What does it mean?
Yeah, I mean it's an RTA fast or fall from high.
Okay. You know, 1 week back, I was involved in an RTA, but I'm fine. I mean, my RTA was like, and I'm a good driver, by the way. It was the fault of the other guy, surely. He bumped into me from the back, and it was just a small bump, okay? It just broke, the back bumper. But I definitely didn't get CT scan for that. So what kinds of RTA, that's the question, what kinds of RTA would qualify as dangerous mechanism?
Like a cyclist hit by motor vehicle or something like this.
Yeah, pedestrian accident.
Pedestrian, yeah.
That's one thing, yes,
Or
pedestrian
fall,
accident.
yeah, or fall from more than 5 stairs.
Fall more than 5 steps, yeah, very excellent, doctor. And?
Oh, ejection from a vehicle, like.
Yeah, the patient has been ejected from the vehicle. Yeah. That's very excellent. So those things are just examples of what qualifies as dangerous mechanism of injury. So please be careful in the exam. Just keep an eye on that in the exam, because they keep showing those stuff. They don't give you any indication, but they give you a high risk history. Please don't miss that in the exam. High risk history means CT scan, just on the account of history, even if the patient is absolutely normal otherwise. Okay, perfect. Let's go to the next question. Okay.
27-year-old. Oh, sorry. Next one. Is that the same question? 27. I can't see the next one. Oh, what is the earliest sign of increased intracranial pressure? Hypertension, bradycardia, altered mental state, irregular respiration. And yeah, Doctor, I've got this message, International Surgical Boards, over the last one, so I can't read it.
General convulsion.
Okay.
Generalized convulsions.
Oh yeah. So I know this one. It's altered mental state.
Yeah. Altered mental state, definitely, because remember that all of the components of what's that called? What's that name of that? Yeah. The name of
Cushing's
when there's high Cushing's triad. All of the components of Cushing's triad are late manifestations. All of them are late manifestations. Hypertension is a late manifestation. Bradycardia is a late manifestation. Problem with this, all of them means imminent brain herniation. So they are not definitely early, right? Altered mental state definitely is bad. Early situation. So let's go to the next one. If you don't see the last option, it's benzocaine.
Okay. Which of the following anesthetic agents is of choice in Beer's block? So bupivacaine, prilocaine, which is the right answer, lidocaine, and procaine, whatever he says. So it's definitely prilocaine. Very common question. Come up a lot.
Very, very common. So yeah, prilocaine. Let's go to the next one. We already know that. Okay, let's move to the next one. Last option is mandible.
Following facial trauma sustained during road traffic accident, a 30-year-old man complains of lost sensation on the side of the nose, lower eyelid, cheek, and upper lip. Which bone is fractured? Zygomatic bone, maxilla, nasal bones, frontal bone, and maxilla. So this question actually came up in April, actually, just gone. And I think the answer is zygomatic bone. And I had a lot of thinking about this in the exam, if it was going to be maxilla or not, but I went for A. I think that was the right answer.
Okay, so let's analyze that. They said following a facial trauma sustained during RTA, 30-year-old man. What does he complain of? He complains of lost sensation on the side of the nose and lower eyelid and cheek and upper lip. So what nerve is damaged here? What's the name of the nerve?
The facial nerve, zygomatic branch. I'm not sure.
I think inferior optic nerve.
No, guys. No? Facial nerve is not sensory, and optic nerve is optic nerve. It's not optic nerve.
Trigeminal then.
It's a branch of trigeminal.
Yeah, it's a maxillary, infraorbital.
Infraorbital, yes, infraorbital nerve, right? The infraorbital nerve, a branch of the maxillary nerve, is the nerve that is supplying the side of the nose, most of the cheek, not all of it, but most of it, the upper lip and the lower eyelid. Is that right? That nerve courses where? We have to deal with this problem. So this nerve originates from the maxillary nerve where? What's the point of origin? It's coming from where? I know maxillary, but which anatomical area? Pterygopalatine fossa, and then it enters into the orbit via the inferior orbital fissure, and then there's a canal there. It enters into this canal within the maxilla, and then exits just below the orbit, right, from the infraorbital foramen, and then it will supply those funny stuff. So it means that if the maxilla is fractured, definitely this nerve will be involved, right, according to this question. So the answer should be maxilla. Is that right? Do you agree with me?
That makes sense, yeah.
Right? It's an anatomy question. There's no trick in there, no magic. Okay, let's go to the next question. All right, yeah.
A 60-year-old female is started on steroid therapy due to an acute flare of systemic lupus erythematosus. Following this, she develops painful vesicles involving the tip of her nose. The nerve involved in this case is external nasal, supraorbital, supratrochlear, lesser occipital, and can you tell me what E says, please? It's covered up.
None of them.
Okay, so I think I remember something about the nose is also supplied part of the ear, so I can't remember where I'm remembering that from, but I might guess at C. I would be just a guess.
Okay, so C, B. Someone said B. Someone said A. Dr. Muhammad said A. Dr. Hanan said A. Okay. Now people are piling up against A, for A. Sandy, Murtada, they're all saying A. Okay. Why A? Can anyone just unmute themselves? Anyone who answered A, just tell me why.
Because the other options, I think it's far, far away from the tip of the nose, like lesser occipital, supraorbital, and supratrochlear.
Yeah, so that's one reason that definitely the external nasal nerve is a branch of, yeah, it's of what? The external nasal nerve comes from.
I guess it's a branch from the branch of mandibular, maybe maxillary.
Ophthalmic, I guess.
Okay, okay, but I want a more accurate answer. It's, of course, it's from ophthalmic, but I want which branch of the ophthalmic nerve, because that can be a question, right? So it is a continuation of the anterior ethmoidal nerve, right? The anterior ethmoidal nerve, right? Or that is coming from nasociliary, so anterior ethmoidal. The anterior ethmoidal continues as external nasal nerve. An external nasal nerve supplies tip of nose. Is that right? That's the correct answer. External nasal nerve, right? So this is reactivated herpes zoster, right? That's called what? The activated infection is called what? I forgot. When it is reactivated, it has a special name. Reactivated infection. I think that's called the primary infection is called varicella, right? Primary infection is varicella, and the reactivated infection is just herpes zoster. Shingles, yeah, shingles, yeah. So that can be also called shingles. So external nasal nerve. Anyway, of course, the cause here is the steroid therapy, right? Patient is immunosuppressed, so went on to have a reactivated infection. Let's see the next one.
Following a RTA, a 30-year-old man sustains extensive facial trauma. There is loss of sensation for the lower gums, lower lip, and chin. Which nerve is damaged? Mental nerve, inferior alveolar nerve, buccal nerve, infraorbital nerve, and whatever he says.
Superior alveolar.
Right. I think it's A, mental nerve, but it could be B, so I'm not sure again.
Okay. All right. Okay, so the answer is inferior alveolar nerve, right? Because the inferior alveolar nerve is actually coming from the posterior division of the mandibular nerve, and it's a branch of the posterior division of the mandibular nerve. It enters into the mandibular canal. Inside of the mandibular canal, it supplies all the mandibular teeth, right? Except the incisors, because it will divide and give incisive nerve. So the main trunk does not supply the incisors, but the main trunk supply all of the other teeth, approximately, I think, to my own knowledge. But within the mandibular canal, it divides into incisive nerve, supplying the incisive teeth, and the dental nerve, which supplies the chin, the lower lip, both skin and mucosa side of the lower lip, right? So if there's injury to the mental nerve, there will be sensory deficit only in this region, in the lip region, but not teeth, because remember, already supplied before it gives mental. But inferior alveolar itself, if it's damaged, not only the lip will be numb, but also the gums and teeth, mandibular gums and mandibular teeth. So that's why the answer for this question is option B. Feel free to stop me at any moment if you want to discuss something. Okay, let's move to next Next
A
one.
40-year-old man develops a lesion at the superior orbital fissure. What is the expected sensory deficit? Lost sensation over lower lip, upper lip, anterior scalp, posterior scalp, or the anterior 2/3 of the tongue?
All right. So
I think it's anterior scalp.
that's correct. It is over the anterior scalp. Okay, so something that's called superior orbital fissure syndrome. In superior orbital fissure syndrome, there's some kind of lesion around the superior orbital fissure. So all those structures traversing this naturally will be affected. So these include all of the nerves that supplies extraocular muscles. So there'll be total external ophthalmoplegia. All of the muscles supplying the extraocular muscles, all of them will be paralyzed. So essentially, the patient will not be able to move the eye in any direction. There's also internal ophthalmoplegia because the oculomotor will be also involved. In this region also coming is the ophthalmic nerve. One of the terminal divisions is the supratrochlear and supraorbital, which supplies the anterior half of the scalp, sensation I mean, right? So naturally, if this is affected, then anterior scalp sensation will be lost. As simple as that. Let's move to the next one. Here's that, trying to explain what happened. Let's see the next one.
A 60-year-old man presents. A 60-year-old man presents. 60-year-old man presents with unilateral isolated buttock claudication. Which of the following vessels is affected? Common iliac, internal iliac, external iliac, aortoiliac, and whatever the last one says, please.
Common femoral.
So I think the external iliac supply the buttock area, so I'll guess for C.
Okay, so if we say that this is the aorta, right, divides that L4 into two common iliacs, right? Two common iliacs. Each common iliac will give internal iliac. This is internal iliac artery, which supply pelvic organs and gluteal region, right? Through the superior and inferior gluteal arteries. So it will supply the pelvic organs, all of the pelvic organs except the gonads, the ovaries, and the females. But almost all the other pelvic organs are primarily supplied by the branches from the internal iliac, including the gluteal regions, because, as I told you, the internal iliac artery give rise eventually to superior and inferior gluteal. Anyway, this will continue as external iliac after the division, and external iliac will continue down to the lower limb and supply the thigh and everything below that. So if there is a lesion in option A, common iliac, which is here, it means what? If there's a lesion in the common iliac, it means the entire lower limb will be affected, as well as some pelvic supply will be limited. There will be compensation from the other side, definitely, but it will be limited, right? So the patient cannot have isolated buttock claudication. Not isolated, meaning there will be other things with it, like thigh claudication, calf claudication, foot claudication, wrist pain, whatever. So it cannot be A. If you choose option C, which is external iliac, the pelvis and gluteal regions will be spared. So the buttock should not undergo claudication, right? So essentially the thigh and below will be affected, but gluteal region will not be affected.
So it's B then.
So that's B, right? Look, this problem is very rare. The problem where there's isolated internal iliac artery disease is extremely rare problem. And in a lot of patients, it's asymptomatic. In a lot of patients, there's no symptoms at all. It's an asymptomatic problem that you don't even, be aware of. Why? Because there's collateral supply. Usually there's good collateral supply from other vessels, like the other internal iliac, for example. There's anastomosis between the two sides. But in some patients, unfortunate patients, the anastomosis is not well developed. It's just the anatomy of the person. And they may start developing claudication on that side, which is rare. And it is isolated only to the body, which is very rare. Okay? But that's a question appeared in May 2020. This is May 2024, by the way, if you want to know. So means the answer to this is option B, right? Internal iliac. Let's move to the next one. Okay.
A 68-year-old smoker develops peripheral vascular disease. What is the effect of smoking on blood vessels which promotes development of arterial disease? Stimulation of nicotinic receptors, release of free radicals and endothelial damage, which I think is the right answer. Smooth muscle proliferation, lysosomal enzyme activation. I can't read E, but I think the answer is B anyway.
Yeah, so it is B, right? Free radical. Actually, the exact mechanism of how smoking causes, of course, we know smoking causes vascular disease, but the exact mechanism is debated a lot. But this is the most accepted thing, that it does damage the endothelium. Now, I remembered something, you know, radiotherapy for curative intent or whatever. Do you want to talk a little bit about radiotherapy? I think that's a weak point in for us surgeons, because we don't really deal with that usually. But they ask us about this. They will ask us about this. Now, radiotherapy situation. So, first question, simple question. How does radiotherapy work? How does it really work? What's the mechanism of action of radiotherapy, if you get asked that question?
You've got energy, high energy, that's then killing the cells that the energy hits.
Yeah, so there's some energy. Oh my God, okay. Sorry. So there's some energy that is delivered to the tissue, and that energy does something somewhere, and that somehow cures the patient or somehow palliate the patient's symptoms, right? Okay, let me explain. Let's go back here. So here's your DNA. Okay, wait a minute. Let's spend a few minutes talking about this. So let's just enlarge this. Okay, so here's your DNA. Okay, that's suppose your DNA, double strand. Now, when radiotherapy comes, when this radiation comes, it does two things primarily. It's usually ionizing. It's ionizing radiation. It's ionizing radiation. One mechanism of action is that it will ionize the DNA molecule itself, right? Number one, it's going to ionize the DNA molecule itself. That's number one. This is called direct mechanism. This is called direct mechanism. The other mechanism that it will ionize, of course, every cell has water in it. It will ionize the water which is surrounding the DNA molecule. The water which is surrounding the DNA molecule will get ionized and generate reactive oxygen species, primarily hydroxyl radicals, which is like this, hydroxyl free radicals. And these hydroxyl free radicals will secondarily damage the DNA. And this is called indirect mechanism. Indirect or indirect mechanism. So what do you think? Which one has greater effect? Which one has greater therapeutic effect? The direct mechanism, where the radiation directly ionizes the DNA molecule, or the indirect mechanism, where the radiation ionizes surrounding water and generate hydroxyl groups? What do you think will have greater effect? The indirect mechanism is responsible for most of the job. The indirect mechanism is responsible for the majority of the job. Now I have an additional nice question, which is very, very common, especially in the OSCE situations. What do you think? If this cell, this is a malignant cell we're talking about, if this cell is hypoxic, there's not enough blood supply to it, or the patient is anemic or have respiratory disease, anything that you can think of, where oxygen delivery is not good to the cell. And then we used radiotherapy on this cell. Do you think hypoxia will affect it in any way? Yes or no? Do you think hypoxia to the cell will affect radiotherapy in any way? Okay, so Dr. Rimas said yes, it affects. How does it affect? Would you say it will increase the effect or reduce the effect of radiotherapy? It will decrease the effect of radiotherapy. You are very excellent, Dr. Rimas, really. Yes, that's correct. It will reduce the effect of radiotherapy. How? This hydroxyl situation is not permanent fixing damage. Now, in the presence of good oxygen supply, to the cell, it will convert it into peroxyl radicals. Peroxyl, it becomes peroxyl. Peroxyl is more fixed damage. It's long-lasting damage, is more damage. So what does it mean? It means that clinically, we need to treat hypoxia before radiotherapy. So if the patient is anemic, we will correct that. If the patient have respiratory disease, we'll try to control that. We'll try to improve oxygenation of the cells, of the malignant cells, so that they die more, right? So that radiotherapy kills them more. So hypoxia is not good for radiotherapy. Hypoxia is not good for radiotherapy. Okay? You know, sometimes you hear one tumor is very sensitive to radiotherapy or chemotherapy. And other tumors, they tell you they are radio resistant. They don't respond to radiotherapy. Why do you think that is? Do you have any idea? Why do you think that the effect of radiotherapy is different? We commonly hear this, right? For example, seminoma is very radiosensitive, right? Very radiosensitive seminoma, for example. But not all the time. So hypoxia is not tumor specific, right? Hypoxia is not a tumor specific thing. Do you know P53? I'll tell you a very interesting fact. Do you know P53, right? It's a tumor suppressor gene. P53, among its many functions, if the cell is damaged, if the DNA of the cell is damaged, it will cause the cell to commit suicide. It will cause the cell to kill itself through apoptosis. One of the functions of P53 has mainly three functions, guys. Three functions mainly. Function number one, it arrests cell cycle. Without going into detail, if you want, I will jump into it, but I don't think that's very relevant for the exam. But at least know the three functions. Function number one, it's an emergency brake. It breaks the car, right? It causes arrest of cell cycle. That's one important function. The second function, it repairs DNA. DNA damage, it repairs it. Function number three, if DNA damage is so severe and beyond repair, it will just kill the cell. So imagine with me, if a cell have P53 mutation, would you say that radiotherapy will be better or not that effective? If there is P53 mutation, yeah, radiotherapy will not work. Radiotherapy is not gonna work because radiotherapy damages DNA, right? When this damage occurs, p53 is upregulated and kills the cell. But if someone there is mutation in p53, which is very common among a lot of types of cancers, when radiotherapy is delivered to the cell, when it's delivered to the cell, what's going to happen? Nothing much, not a lot actually. The DNA will be severely damaged, but there's no mechanism to kill that cell. So sometimes it can be even bad. It can even worsen the situation because it accumulates more mutations. So we've discussed one factor, which is oxygen delivery to the cell. The second factor is p53. I'm about to be impressed by someone. What is the third factor? What is the third factor? Do you know Gray? Not Gray's Anatomy, right? Gray's Anatomy, that series is not Gray's Anatomy. I mean other Gray. Gray, and they give it this GY, Gray. What's that? We said that radiation, when applied to tissue, you're actually delivering energy to the tissue. Dr. O said that when radiation is applied to tissue, tissue is energized. Energy is added to the tissue. That's correct. Now, the amount of energy absorbed by the tissue, now be careful, the amount of energy absorbed by the tissue is called Gray. That's the unit of, it's a unit of measurement. Unit of measurement of what? Amount of energy absorbed in the tissue by the radiation. So let me tell you something. Suppose actually 1 Gray is equal to 1 joule of energy per kilogram of tissue, right? That's the standard thing about Gray. But that's not the whole thing. That's not the entire thing, because different radiation have different effects on the tissues. For example, X-ray radiation or beta radiation may cause little damage, but alpha particles cause significant damage. So depending on the modality of radiotherapy, even with the same amount of energy, the effect is different, right? So what is the unit to measure the effect of the absorbed dose on the biologic tissue? Not just the energy, the effect. What's the unit that we use in radiotherapy units to measure the amount of damage to tissues, or the effect actually? This is called sievert, right? This is called, the unit is called sievert. So what is the difference between sievert and Gray? Gray is the amount of energy absorbed by the tissue. Sievert is the effect. Is the effect of that, regardless of the amount of energy, is the effect on the tissue. Okay, so okay, we're not gonna become nuclear scientists right now. Let's go to the next question. Okay, something happened. Let's go down. All right, so let's see. Yes. Yeah.
A 50-year-old diabetic man presents with an ulcer at the plantar aspect of the foot, overlying the metatarsal head, along with the swelling at the ankle area. What other manifestation may be expected in this patient? Eczema, lipodermasclerosis, APBI more than 9, Charcot joint or venous ulcer.
Charcot joint.
Okay, Dr. Sahar said Charcot joint. What do you think, Dr. O?
I'm wondering if a few of them could be possible. Like if he's diabetic, could he have Charcot joint and venous ulcer? Or...
Okay. I agree with you in this. I think that's correct. That diabetes can increase the risk of venous. I'm not sure, really, to be honest. I know a lot of risk factors for venous disease, but diabetes, venous disease, I'm not. I think in the back of my head somewhere there, I heard about it before, but I'm not quite sure. But of course, we know that diabetes causes neuropathy, and neuropathy causes Charcot joint, right? Over that's severe degree Charcot joint. So it's a more correct answer. I think it's my own belief. I think it is a more accurate answer. Because not only that, the site of the ulcer, it's just not telling me it's venous at all, right? The site of the ulcer is plantar aspect of metatarsal heads. That's area for neuropathic ulcers. Is that right? It's a pressure area. So it is an area for neuropathic ulcer development, definitely. The heads of the metatarsal bones, amongst the commonest locations. So definitely it is mostly Charcot joint. That's the explanation. If you want it, you can take a screenshot for it and study it if you want. Okay, let's move to the next one. Okay, yeah.
The drugs mentioned below all reduce cardiovascular morbidity and mortality except for ACE inhibitors, antihypertensive drugs, aspirin, cholesterol lowering drugs, and I can't see E.
Oxy, funny name, oxypentyphidine.
Okay, by process of elimination, I'll guess for E because A, B, C, D can help cardiovascular.
You are very right. So that's correct. Oxypentyphidine. I'm not sure if I'm pronouncing this correctly. This does not help with cardiovascular morbidity and mortality. Yeah, you are correct. Right.
A 60-year-old man with atrial fibrillation has recently underwent femoral embolectomy to treat an acutely ischemic limb resulting from embolic occlusion. Following this, he develops tense calf and leg pain. Which of the following is most likely? Hemorrhage into the leg compartment muscles, reperfusion injury, post-thrombotic syndrome, arterial vasospasm. What's E, please?
Residual clots.
Okay. So it kind of sounds like I'm not sure. Actually.
Okay, give it a go. Try to think more about it. So look, he's in atrial fibrillation, and we know that he had acute limb ischemia. Okay, embolic occlusion. That has been removed. So he did femoral embolectomy. The embolus is now removed. Now the limb is refilled with blood, but then everything became swollen and painful and everything. So what happened? Mostly.
Everybody seems to be going for B, so I'll go for that then, reperfusion injury, but I don't know the mechanism.
Yeah, so it's reperfusion injury. Reperfusion injury is the type of injury to the tissues and also systemically that occurs when a limb is reperfused after a period of prolonged ischemia. Okay, so when a part of the body has been undergoing ischemia for a long time, the muscles, everything is suffering ischemic injury, and the cells are undergoing necrosis. They are undergoing necrosis. So let me just draw a simple diagram here. So this is a blood vessel, suppose, right? And this is the endothelium of that blood vessel. And there are some surrounding muscles and funny stuff around that vessel, right? Suppose this is the muscle around that vessel. So when there's no blood flowing here, right, the vessel itself gets damaged. The endothelium itself suffers hypoxia and become damaged and gets very leaky. They become very, very leaky. And also the muscles here, they die off and they start releasing something like potassium, like uric acid, like phosphates, right? Like lactic acid from within the dying cells. Now, when blood flow resumes, first, blood is coming in with oxygen. So there is also oxidative stress, and reactive oxygen species are added here. It causes even further damage, okay? In addition to the damage that has already been done. Now, blood which is coming to this area the plasma will easily leak out because these capillaries are damaged. So the area will swell. And of course, there are compartments, so it cannot swell forever, right? So there's a compartment that is holding them. So pressure is going to go up, right? So you can think of it as a reperfusion injury is a cause of compartment syndrome, is a cause of rhabdomyolysis, is a cause of hyperkalemia, is a cause of hyperuricemia, is a cause of acute kidney injury, is a cause of sudden cardiac death due to dangerous ventricular arrhythmias, and of course of metabolic acidosis. Is that right? So essentially it's reperfusion injury. Those patients that have been presenting with prolonged ischemic limps, most vascular surgeons, they perform prophylactic fasciotomies. Prophylactically, right? Prophylactically fasciotomies. I've explained in the lecture, vascular surgery lecture, in details when to do it and when not to do it and everything. Okay? So it's reperfusion injury, definitely. Reperfusion injury. Perfect. Let's look at the next question.
A 43-year-old diabetic man is undergoing a major abdominal surgery. Which of the following anti-diabetic drugs should be stopped 3 days before surgery? I remember this question came up in April again. Metformin is the right answer, but metformin, glycoside, dapagliflozin, sitagliptin, or acarbose. So metformin should be 2 to 3 days before surgery because it can cause acidosis for some reason.
I agree that metformin causes acidosis. In some units, they don't stop metformin for every surgery. It's controversial at which level of surgery you stop metformin, but in any case, it can be stopped a day before surgery. I don't think that you need to stop metformin 3 days prior to surgery. You can stop it, but the day before the surgery, I think it's sufficient. I'm not...
In the exam, it actually came up as 2 days. It didn't, in the exam question, April 25, it didn't say 3, it said 2.
Even 2 days, right? Even if they say 2 days, metformin stopped a day prior, even if they said 2 days. So actually, the majority of anti-diabetic drugs, oral anti-diabetic drugs, they are stopped the day before surgery. They are almost all of them are stopped the day before surgery, except the gliflozins. The gliflozins like dapagliflozin, right? Sitagliflozin. Those drugs which are belonging to which class? Yeah. Which class do the gliflozin family belongs to? Sodium, glucose, right? Sodium glucose transporter 2. Sodium glucose transporter 2 inhibitors. Okay, you know that in the kidney, I'm just going to explain it real quick. In the kidney, glucose is primarily absorbed in the proximal tubule, right? Via a sodium-dependent mechanism, right? So there's a carrier here, right, which carries sodium on one side and glucose on the other side. So it is coupled with glucose. and this is a form of secondary active transport. Sodium is taken in as well as glucose are taken in. So this is co-transport, right? This carrier is called SGLT2 or sodium glucose transporter 2. Simply, these classes of drugs, they block this transporter. So they block glucose intake by the proximal tubular cells. So simply glucose is thrown in urine. That's how they work. That's how they reduce blood glucose level. Right? Now, I have a funny thing to tell you. Of course, these drugs, they need to be stopped 2 to 3 days before surgery. That is, you cannot stop them on the day of surgery because their effect is going to take more time to disappear. But the thing is that I want to tell you something. Have you know, of course, you know about diabetic ketoacidosis? Okay, diabetic ketoacidosis, one of the diagnostic criteria to diagnose it is hyperglycemia. These are one of the diagnostic criteria. One of the diagnostic criteria is high blood glucose, in addition to ketones and some other criteria. But one of the diagnostic that needs to be present. Without it, you can't diagnose it. That needs to be present. If there's hyperglycemia, right, and hyperketonemia, right, and hyperketonuria, the patient will be diagnosed as diabetic ketoacidosis, right? Now, with dapagliflozin or other flozins, if you do surgery without stopping these drugs at appropriate time interval, what will happen to the patient? Excellent. Euglycemic acidosis. Euglycemic ketoacidosis. Can you believe it is normal blood glucose, but there's ketoacidosis? Why blood glucose normal? Because that's lost in urine, right? And when it is lost in urine, you're actually, in addition to the surgical stress, you're actually depriving the patient from energy sources. So more lipolysis will occur, more fatty acids will be oxidized, more ketone bodies will be produced. Is that right? That's an important thing to know. You know, if you want more about this topic, perioperative diabetic management, the lecture is on the website for free, right? Even if anyone here is not on the course, they can go and watch it. It is for free. And it explains everything into detail, how to manage insulin, how to manage every diabetic oral anti-diabetic drug. Okay, let's take this question, yeah, and then we'll take a break.
A 75-year-old man presents with massive central lumbar disc herniation. He complains of pain and weakness of both lower limbs. Which of the following features will not be present? Hyperreflexia, saddle anesthesia, urine retention, weak or absent ankle reflex, weak or absent knee reflex. I don't know.
Okay, so this is, what's the diagnosis here? Massive central disc prolapse, right? Lumbar disc prolapse, lumbar disc prolapse, central massive lumbar disc prolapse, cauda equina, right? Cauda equina syndrome or cauda equina. I'm not sure about the pronunciation, really. I have troubles with that, but cauda equina or cauda equina syndrome. This is a neurological emergency, right? This is a neurological emergency. It needs to be dealt with within 1 day, within 24 hours. Otherwise, there is permanent neurological deficit that the patient will be suffering with for the rest of their lives, basically. So it means that you have to really fix that. The first step in the management is to confirm the diagnosis with neuroimaging. Generally, best is MRI, right? MRI to confirm the diagnosis. Next step is emergency decompression. Now, the coda equina fibers, they are lower. The motor fibers inside of them are lower motor neuron fibers. They are not upper, right? Because the spinal cord ends at L1 in the adults, in front of L1. So anything below L1 are nerves. All of the motor nerves below L1 are lower motor neuron nerves. So if they are damaged in anywhere below L1, the manifestations will be lower motor neuron lesion. That is hyporeflexia or areflexia, hypotonia, absent Babinski, right? So it means option A, which is saying hyperreflexia. Hyperreflexia is a feature of upper situation, right? Upper motor neuron lesion. So it's not going to happen. Hyperreflexia is not going to happen. Now, I'll tell you something. If there's cerebellar lesion, what will happen to the reflexes in general? If there is a cerebellar lesion, suppose someone have, I will ask something. I will ask two questions. Suppose someone have left-sided cerebellar tumor. Left-sided cerebellar tumor. What will happen to the reflexes and on which side of the body? The manifestation will be on the left or right, and what kind of manifestation is that? Yeah. Upper motor hyperreflexia. On opposite side. No. Look, when there's cerebellar lesion, usually and almost always, the manifestations are ipsilateral, on the same side. Look, when someone have left-sided cerebellar lesion, and you examine the patient, right? So the patient will stand up and you will do gait assessment. So the patient walks, right? They walk with broad-based gait, or some people call it drunken gait or cerebellar ataxic gait or whatever, and they tend to fall to the left. They fall on the left side. Is that right? They fall on the left side. And when you examine their hand, their left hand, it will show dysmetria, intention tremor, leukokinesia, and their left leg will show impaired heel to shin test. Is that right? And what else? Of course, they will have staccato or scanning speech. It's called scanning speech or staccato speech. And what else? Yeah, they will have, yeah, if someone will tell me this last manifestation, they will be very great. Okay, nystagmus, and what else? Nystagmus, there will be nystagmus. But ataxic saccadic eye movement. Have you ever heard about that? Ataxic saccadic eye movement. Ataxic saccadic eye movement. Ataxic saccadic eye movement. What's that? So someone said hypotonia. Yes, there's hypotonia, and the reflexes, my initial question, the answer to that, the reflexes are hypotonic. Hyporeflexia also. These are called pendular reflex because they are slow in their rise and slow in their fall. But the thing is that, what is ataxic saccadic eye movement? What's that? It's tested clinically. You should know that if you want to go to the OSCE too. Yeah. Now, the examiner may say, for example, what are the eye signs in cerebellar disease? The eye sign in cerebellar disease include, number one, there is nystagmus. Usually the rapid phase of the nystagmus is towards the side of the lesion. Like everything in the cerebellum is towards the side of the lesion, essentially. Number two, there is, yes, impaired smooth pursuit. I will talk about that. And number three, ataxic saccadic eye movement. Let me tell you what saccadic movement is, okay? And then we will take a break. So I really want you to be clear about that. It has a lot of points that are clinical. I will tell you a story. Okay. Suppose someone is now in the park, right? I like park stories. He's in the park. Okay, this guy is in the park and he's looking. This is the guy, right? And this guy is, you know, postpubertal hypertestosteronemia, and he's looking for a wife. Okay, this guy is looking for a wife. Suppose he's looking at a dog, right, in the park. He's looking at a dog. I don't know, that's kind of rat or whatever. Imagine it's a dog. So he's looking at this dog. But suddenly, a beautiful lady who he thinks he's going to marry her, she's here. This is the lady, right? He immediately, she catches his attention. So he immediately moves his gaze. Now listen carefully. He immediately moves his gaze from the dog to the girl, right? From the dog to the girl. This rapid movement from one object to the other, that's called saccades. This movement, it's a normal movement. It's called saccades. Saccades, okay? Now, how does that movement happen? It's very complex issue. But the thing is that, suppose this guy has cerebellar lesion. The girl is here, the dog is here. So when he moved his gaze from the dog to the girl, his eyes went past the girl. His eyes went past the girl and then immediately comes back to her in a corrective manner, right? So you can relate when a person that has cerebellar lesion and you are doing nose to finger test, they have past shooting, right? Or dysmetria. That also happened in the eyes. When the guy looked from the dog to the girl, his gaze passed her and then came back to her again. That's called ataxic saccadic movement. Ataxic saccadic movement, right? It has to do something with the medial lemniscus pathway, which also have something. It is related also to internuclear palsy. These are things that we will discuss sometime later. Okay, we don't want to spend a lot of time on that discussion. But when the questions about internuclear palsy and things like that come, I will be happy to discuss that with you. Okay, so perfect. Let's take a break for, all right, let's say 15 minutes is okay for you guys? What do you think? 15 minutes? Okay, 15. Perfect. So let's take a 15 minutes break and then we'll continue. So see you in 15, guys. Thank you so much for your attendance. Thank you.